Thank you for joining International Medical Corps and the Florida Association of Community Health Centers for our webinar today. Today's going to be on medical surge during COVID-19 and flu season. So this is the second of a two-part series with the first webinar held last Thursday on risk communication. So my name is Ryan Bresnahan. I'm the Training and Operations Officer with the Emergency Response Unit at International Medical Corps. And I'm joined by my co-host, Gianna Van Winkle, Director of Emergency Management with FACHC. And we know that you are all incredibly busy with your organizations, so we appreciate the time that you're spending with us today. Before we get started, I'd like to address some administrative considerations. So we do ask that participants remain on mute throughout the webinar. We will have a question and answer segment following the presentations. Please feel free to ask your questions in the chat on the bottom of the screen. And we will be monitoring chat for your questions throughout. Furthermore, a link to the evaluation will be made available in the chat. It's going to be very brief, so please complete it at the conclusion of the webinar, and we really appreciate your feedback on today's session. It helps us for future programming. So now I would like to introduce our speakers for today. Today we have with us Dr. Natalie Moore. She is an emergency physician at the University of Connecticut Health Center. And she completed a 2-year fellowship in disaster medicine with a master's in public health after her residency. She's been volunteering with International Medical Corps since 2015 to disasters around the globe, most recently, and this is where I met her, as a member of the assessment team in Grand Bahama Island following Hurricane Dorian. And during the COVID-19 response, Dr. Moore helped design UConn's COVID disaster plan, which led to the mobilization of emergency field units for emergency room surge and the orientation of staff to support the COVID-19 response. Dr. Moore has also led the COVID-19 course for the 3rd and 4th year UConn medical students and provided care for a number of COVID-19 patients in the ED. This is also not so much an introduction, but a few words on Gianna Van Winkle. And Gianna's been working in community-based healthcare since 2009, when she was hired by a Miami-based FQHC to oversee the health center's risk management and compliance programs. In 2014, Gianna relocated to New York and served as the program manager for the Health Center Support Program at Chicanas, which is the state's primary care association, focusing both on emergency management and FQHC program compliance. Gianna returned to Florida in 2020 and joined FACHC as the Director of Emergency Preparedness there. And Gianna holds a master's degree in business administration with a specialization in human resource development from Nova Southeastern University. And she's also obtained certification in healthcare compliance, practice facilitation, and the CPI Prepare program. So thank you to both speakers for joining us, and we'll also be joined by leaders of the community health centers of Pinellas to hear about their experience during COVID-19. So before we get started, just a little bit about International Medical Corps. So we are a global humanitarian organization dedicated to saving lives and relieving suffering. We were established in 1984 by volunteer doctors and nurses, and we are a nonprofit with no political or religious affiliation. We now have more than 7,000 staff around the world, over 90% of which are local. And our mission is to improve the quality of life through health interventions, and related activities that strengthen underserved communities worldwide. With the flexibility to respond rapidly to emergencies, we offer medical services and training to people at the highest risk, always working to strengthen local healthcare systems and promote self-reliance. So in accordance with our mission, International Medical Corps has been responding to the COVID-19 pandemic around the world, including here in the United States, deploying medical supplies, training health workers, setting up triage and screening sites, and more. But now I'd like to turn it over to Gianna to speak a little bit about FACHC. So over to you, Gianna.
And again, not so much of an introduction, but really here just a shout out that I'd like to give to our partner, International Medical Corps, for supporting our health centers And I know we also have Tom Knox on the line. He's here as an attendee sitting in the health center side, but he has also worked hand in hand with IMC to really establish this strong partnership. And we so value your support. You see here some examples of initiatives that IMC has supported through FACHC. And one of those being the training on health center management for emerging infectious diseases, rolled out in late 2019 and early 2020. So, you know, with those types of initiatives, we really see how applicable, you know, this support is and how we can turn this into actions that really help health centers respond and take care of their communities. So with that said, you know, today's content is an evolution of some of the slides within that full day training. So we've broken it down bite size and hope it's helpful for you today. I know we're all in the midst of this response, but as we come together, we have opportunities to learn from each other. So thank you for being here, and thank you to all of our presenters and IMC.
Great, thanks, Gianna. So I want to go over quickly the objectives for today. So we want to identify key components, and we've highlighted them as this 4 S's: the space, staff, stuff, and systems involved in medical surge. This is specific to a large-scale infectious disease outbreak, but the space, staff, stuff, and systems is consistent with medical surge for any emergency. We also want to look at the elements of a medical surge plan and to review health center considerations for adaptation. And then we also want to hear from the community health centers of Pinellas about their lessons learned from mobilizing surge sites for community testing. So right now, I just wanted to take a moment and launch this poll. It has 3 questions. Just trying to get a lay of the land for surge site experience that all of you have experienced. So we are going to leave this up for probably about 1.5 minutes just to gather some of your feedback on this. There are 3 questions. Okay, so we can end the poll. And I want to share the results with everyone. So it looks like most of the respondents have experience with using surge sites for drive-up testing. It followed closely with walk-up testing, assessment triage prior to entering clinic, and the use of mobile unit. And we can bring these up too, I think, as a reference point for later on in the session. But in regards to partnering for surge planning, the majority have worked with the local health departments, followed then by the coalitions, then by other FQHCs and FACHC, and then lastly with hospitals and other, which we can look to the chat to find who might be the other. And then lastly, for if your health center has a surge plan. So about 60% said no, and then 20% said yes, and the last person said not sure. So the good news is that we do have a medical surge template that, that Gianna will be able to share with everyone just as a starting point for some of the the highlights that you'd want to hit in planning for medical surge. So with that, I can bring these up at a later point, but I am going to stop sharing the results, and I'm going to turn it over to you, Natalie, to start with your presentation. Thanks, everyone.
All right. Let me share. All right, so thank you, Brian, and thank you all for being here today. I know that you are all incredibly busy, so I appreciate you taking the time to come and listen. We have a variety of different people here, and your comments would greatly contribute to this discussion. I think we can definitely all learn from each other. So feel free to jump in and comment on the chat whenever you have anything else to offer. Oops, sorry. There we go. just making sure that I see the chat. So you have all been living this pandemic as much as I have. So you really do have as much to offer as I do. And it was very interesting to see the results of the poll. So, as you may all already know, when you have an infectious disease threat, you will likely see a rapid influx of patients into your healthcare system, and this is referred to as surge. Unfortunately, as opposed to what we think about like a mass casualty incident, a bombing, a shooting, a bus accident, where that influx is very, very fast, with outbreaks, it is prolonged over a very long period of time, making it much harder to try to figure out how we allocate some of our scarcer resources. So surge capacity is our healthcare system's ability to rapidly expand beyond those normal services to meet the increased demand for medical care in a public health emergency or a disaster. So surge is a spectrum as we go from our conventional phase, which is normal patient care, to the contingency phase where we have to start making minor adaptations, to our crisis phase where the surge is large enough to cause a drastic change to the healthcare system, resulting in altered standard of care. We also have to augment our healthcare system to adapt to this, and that is surge capacity. So today we are going to outline some of those key concepts. All right, so medical surge is all about reducing your demand and increasing or redistributing your resources to meet this increased demand. When I think about surge capacity, I think about a wonderful mnemonic called the 4 S's, which Ryan has already referred to. This would be creating space to take care of your patients, having enough staff to take care of this increased demand, having enough stuff or supplies, and of course, changing our systems to being able to meet this demand. So reducing the demand is a little bit harder. Some ways that we reduce demand in creating surge capacity are to use some virtual screening, which we'll talk about, doing really good triage, trying to siphon out our worried well, increasing our security. But today we're going to mostly talk about how we increase our supply and redistribute our resources to meet the demands. So one strategy to expand hospital or healthcare system operations is to use a surge site, which it sounds like most of you have already seen being used out there in the community for COVID-19. So this is to increase our space of the 4 S's. So generally this refers to another building or on-site facility or a mobile field tent, like you can see in this picture here with International Medical Corps. So the good things, the pros, is that we can actually separate the infected individuals or potentially infected individuals from other healthier individuals seeking care in the facility for some other reason, whether it be their sprained ankle, their stubbed toe, their blood pressure medications. But unfortunately, there are some cons. So you do not only just have to fulfill the space part of the 4 S's, but these facilities have to be filled with supplies. They have to have enough staff to keep them running. And they do have to have systems in place to care for patients. And we're going to talk a lot about those other 3 S's over the next 3 slides, or a few slides. There are also a lot of different regulations to using surge sites, and these are often laid out by your local public health department. The local public health department will also have to come in, inspect it, and sign off on using one of these surge sites before you're allowed to take care of patients in them. And since you are providing care in a very non-traditional environment, it is critical to ensure that these facilities can support the implementation and recommendations for infection prevention and control practices, which is a little bit harder when you're working out of a tent. So what are some of the uses for these surge sites? This is a great time that if any of you want to jump in and put anything in the chat of other ideas or examples of using surge sites that you've seen, please go ahead and do it. We just came up with this list of some things that you can do with surge sites. So vaccination clinics. This is going to be for flu vaccines. Certainly when we get a COVID-19 vaccine, it will be a good place to dispense these vaccinations. And you can create your surge site so that you can have an area where you're actually vaccinating individuals and then an area that people are still separated by 6 feet, so you're still doing your infection control practices, but watching them after they have a vaccine to make sure that they're not having reactions. I think most of you have mentioned that you've seen COVID-19 walk-through testing sites. So this may be for patients, it could be for your employees, I know we have a lot of them just for first responders and essential workers. This can also be a place to serve as a triage or segregation, which is a great way of keeping your non-infected individuals away from the potentially infected individuals, whether it be flu or COVID-19. A fast lane, also a wonderful way to do it. This could serve as emergency department overflow facility or managing low acuity patients. There are guidelines to using surge sites to care for hospitalized patients, although these guidelines are much more stringent and it's much more difficult to do. Also, it doesn't really work so well for patients with COVID-19, as the reason to admit a patient with COVID-19 is really because they have some sort of respiratory compromise. So they need to be on ventilation, they need oxygen support, they need to be in an isolation room. So as you can imagine, that would be very difficult to do in a tent type setting. Any questions or other comments to add about examples of surge sites? If not, we will move on to staffing considerations. So we'll think about our staff, part of the 4 S's. Planning for additional staffing is incredibly important during a surge, whether it's to augment your healthcare facility staff, your hospital staff, creating a vaccination clinic, creating a testing site, creating a phone screening, if you have an additional assessment and triage area, or some sort of alternative care site, you're going to need extra staff. Some staff will become sick, some staff will become exposed and need to be out because they're being quarantined, and some will not be able to work because of some underlying conditions. I know that given we are going through now the second wave of COVID, we have learned a lot from our staffing considerations and our staffing challenges from the past 6 months or so. So I think that we should improve based on some of those things that we have seen. So when I think about staff as part of surge capacity, I typically think about where can you find additional staff? And in normal surge capacity, thinking about, response to a hurricane or something like that, you first think about using retired staff. So people that used to work at your healthcare clinic or healthcare facility that can come out and fulfill that additional need. Unfortunately, with COVID-19, that's just not a great idea because we do know that it's affecting older individuals worse and making them much sicker. So that one's kind of off the table. Other things is you can redistribute staff from areas that are maybe not being utilized as much to areas like the testing sites, eventually a vaccination site that you may want to bring them. I know at UConn, again, it's a hospital-based system, but we did cancel a lot of the unnecessary outpatient appointments, and we canceled all of our elective surgeries when we first were going into our wave of COVID-19 surge. And this allowed us to have a lot of extra providers. So we took a lot of outpatient providers and utilized them as hospitalists to take care of additional patients in the hospital. And we also took a lot of our surgeons and radiologists and other people that wanted to come in and volunteer because they weren't performing their normal duties doing elective surgeries. And they helped out in the emergency department and in the ICU. And so that was a good way to redistribute staff. Of course, having contracts with non-governmental organizations like International Medical Corps or other agencies, or asking the government for support for staff are other considerations that we can do. I do know that FEMA has the disaster medical assistance teams, and they have also been responding throughout the country to fulfill some of this staffing surge. Next, we're moving on to our stuff. So our supplies inventory. So if you plan on utilizing a medical surge plan, such as an external screening, a surge site, even a vaccination clinic, you are going to have to spend some additional planning efforts on your supplies inventory. This is just a few things that you will need to consider providing for a surge site. This is not an extensive list, and not everything will be applicable to every scenario depending on what you are setting up. Keep in mind that if you are setting up a surge site, these resources are in addition to those keeping your regular facility running. So it's good to think about having multiple supply chains. You're never going to have enough, but you should at least try to buffer yourself if one of your supply chains fails. All right, probably one of the most important components of creating surge capacity is to augment our systems. And some of the surge principles that we think of from a hospital-based system is trying to clear out the number of beds, making way for the influx of sick patients. We use a concept called reverse triage that's been actually quite well validated in the literature to create additional space in the hospital. We also, again, cancel elective surgeries, canceling unnecessary outpatient appointments. And specifically what this would do for the hospital-based system is that it reduces the number of post-op patients in the hospital and increases our bed space. In addition, of course, in the hospital, we cordon off areas to create places where we're just taking care of patients under investigation, and have a separate area for patients that are not considered infectious, and also having two separate sets of staff so that we are not, cross-contaminating and potentially exposing our healthier individuals. And of course, that's a hospital system, but it can translate into a healthcare facility as well. In terms of some of the systems thinking from an outpatient healthcare perspective, these are some of the elements that we think about. So changing our triage system. So if you have a large influx of patients all at once, you might want to consider shorter triage methods, shorter registration methods, and you may want this to be different if you're utilizing a surge site, as opposed to being in the healthcare facility itself. You may need to change your documentation system. You have to think about a patient flow. It should be unidirectional, just like we do in our grocery stores. Having hand washing stations, and of course, making sure that you have your additional precautionary measures, keeping people at least 1 meter apart, installing appropriate ventilation systems. You are going to have to come up with a staffing plan. And again, that is going to be in addition to keeping your regular facility running. So it's typically additional staffing considerations. You'll have to consider if you need laundry services, if you have bathrooms nearby, if you have a clean and dirty utility area, a medication preparation area. So just some additional things to think about in your surge site. And of course, it's very important to have a mechanism to escalate care. So if you can't care for the patients in these surge sites, or you realize somebody is potentially very sick as they come in to get their swab for their COVID-19, you have to have some sort of mechanism, protocols in place to be able to either send that patient into your facility or to a hospital. Having methods to allocate scarce resources is another thing that we should think about within our systems. When designing our surge plan, there is pretty well validated literature on something called a triage committee. If you really do get to that crisis phase of the surge capacity or surge spectrum, that you're really having to augment your healthcare system, and patient care could be suffering. So that's triage committee. We actually put one into place at UConn to allocate scarce resources, but we didn't end up having to use it, thank goodness. And we already did discuss canceling some of the outpatient appointments. Now, I just put this at the bottom to consider conducting a brief drill before using your surge site. When I helped design the one at UConn, I did conduct a little drill, and I had a whole bunch of medical students come out and be fake patients for us. And I was the provider for the surge site, and we identified so many gaps in our systems thinking during this drill. Even though it was only maybe 45 minutes long, there were so many things we didn't think about. For example, just going from the tent space to the emergency department. So our escalation of care, we realized we didn't have radios to be able to do this. So there were a lot of things that we did discover in our drill setting. Any questions about the 4 S's so far? All right, keep moving here. So utilizing virtual screening is another good way to create additional capacity to care for patients and reduce the risk to healthcare providers. So essentially, this is reducing the demand on the healthcare system because you can filter patients before they come into your facility. And this is a really good way of filtering out the worried well. So we did have a dedicated hotline that people could call and talk through their symptoms, and the people on the other end would help them decide, well, do they need to be evaluated immediately by a provider, or should they just be set up off-site with a swab just to see if they had COVID-19. We also were using virtual visits with outpatient providers, and we will talk about that a little bit further. Moving on to triage. So triage is another really good way of reducing demand to create surge capacity. Like I said in the beginning, this is much tougher in an infectious disease outbreak than in a mass casualty incident that people present over a very short period of time because the number of victims or patients is really not known. It's very hard to estimate, and it's really difficult to allocate some of those scarce resources when you don't know how long the public health emergency is going to last. So triage algorithms may also need to be adjusted for the emerging infectious disease. So for example, if you had a new emerging infectious disease that was created by a bacterial pathogen, we would think about creating a triage algorithm that identified people with signs of sepsis, meaning their blood pressures are low, their heart rates are high, they have fevers. This is not the case in COVID-19. In COVID-19, we do know that our sicker patients have 3 major things. Their oxygen is low, they're confused, and their work of breathing is increased. So this is just one way to illustrate how triage algorithms may have to change to identify your sickest patients depending on the emerging disease that you are thinking about. In addition, we do have to incorporate transmission prevention during our triage. So it's really important to screen patients promptly to identify and isolate the potentially infectious cases and take temperatures, of course, ask questions about COVID-19 symptoms, and make sure that everybody is wearing masks, whether they're an employee, a visitor, or a patient themselves. In addition, making sure that everybody is separated by 6 feet. I know in our waiting rooms, we do allow people to wait, but we have every other chair, cordoned off so that people are at 6 feet distances. Other facilities are asking some of the symptomatic patients to wait in their vehicles until their appointment is ready. So that's another good way of separating people. Once we do have a vaccine, triage is also going to be of utmost importance for determining who gets the vaccine first. And the CDC has laid out a vaccine triage in a 3-phase process that they describe in their COVID-19 vaccination playbook. Here is an example of a triage plan for COVID-19 that was developed by the CDC in areas with widespread community transmission. So this has been out there for quite some time, but it's just an example, and I'm sure you have your own triage algorithms, or if you don't, you can utilize this one as a basis and create your own triage algorithm based on your facility. So just to expand a little bit on telehealth, this has become an important mechanism to keep patients out of the healthcare clinics. In my opinion, I think telehealth visits should be for follow-ups and for managing chronic health conditions instead of having these healthier individuals come into the clinics just because they may, need a follow-up for their hypertension and get their medications filled, or their diabetes follow-up. If you are having your staff see patients via telehealth for more urgent care complaints, or for complaints of, fever and infectious symptoms, it's going to be really important to have a mechanism to bring those patients in to be seen and examined in the clinic if the provider thinks that it's critical for the diagnosis, or if they think that, these patients are potentially sicker than they do appear via telehealth. And it is important to remember that use of telehealth is really to reduce surge on all facilities, including emergency departments and acute care facilities, because I know that at least in my area, use of telehealth has actually increased our ER visits somewhat, and created additional influx into the hospitals, which of course is the opposite of what we're trying to do during a pandemic. So Gianna, do you have any additional thoughts on telehealth specific to your area in Florida?
Yeah, well, I wanted to just take over these next couple of slides, the opportunity not to really present, but just kind of comment on some of what I've learned in my short time here at FACHC, but also some of our experience that I took from New York around, how health centers are looking at telehealth and utilizing them. With COVID-19 kind of coming at us hard and fast, we saw a really rapid adoption of telehealth across health centers in Florida and nationwide. I think many were dabbling in this and using it for certain types of services, but we saw that expand exponentially in the early months of COVID-19. Not to say that that was done easily. I'm sure there was a lot of headaches along the way, and I'll look to those on the line. If you'd like to chime in the chat with any thoughts or comments, I would really love to hear them. But with that said, now today, so many months later, we're still seeing telehealth being used quite regularly. With that said, we've also seen an uptick in our ability to see patients in the health center. When everyone was kind of on lockdown, there was a big decrease in those inside the health center while the testing was really taking the forefront. But that said, we are serving patients that have complex needs. So it's very important to have options both for telehealth as well as those folks that need to be seen in the health center to do so in a safe environment. So it's just another way for health centers to look at how these technologies can benefit everyone. There's also, I've heard this from health centers directly, maybe some of your health centers on the line, but PPE has been telehealth has been a strategy to help them conserve PPE, to help them protect their staff that are vulnerable. And like I said, this is also driven by patient demand as well. If a patient didn't feel comfortable coming into the health center, this is another option for them to be seen and managed for their chronic conditions or other things like that. Whereas, we're seeing other, negative health outcomes from COVID that are not necessarily related to this virus. So in an effort to keep the whole community healthy, telehealth is just another tool. And I would ask Kim and Steve also, maybe you can touch on this. We'll hand it over to you in just a couple of moments. So I think that's all I have on this slide, if you want to move on. Yeah.
Sure. So of course, another key component of your medical search plan is how you will share information with your own facility staff, as well as any response partners you may have. At our hospital, I know we have daily conference calls that any staff is welcome to join in. And we do have an email that comes out every day that says exactly how many patients we currently have that have COVID-19, how many we've tested, how many people are on ventilators or in the ICU. And it's really a good way of sharing surveillance information. Gianna, you probably have more to offer on information flow, especially with the coalitions.
Well, I would say just that, health centers are doing this, in day-to-day operations, but we've seen these processes change over the last several months, and health centers have kind of had to adapt to those changes. We talked a bit in the last webinar about just the general importance of communications planning and the ability to push information out in accordance with some risk management principles to staff, other stakeholders, and of course, patients, and public health being a partner, both in creating those communications and in as you talk about surveillance, as in really having that clarity about what's getting reported when and how. And I think too here, when we talk about to exchange information with others, health centers are currently doing a COVID-19 survey weekly for HRSA. They're exchanging information with FACHC as upon request, as it relates to things like the vaccine and other events that are happening. So information is flowing. It's just, it's an ongoing task to wrap our heads around this. And as it relates to surge planning, you can think about all the additional communications that we've had to fold into our plans.
All right, we've already spoken briefly about resource requests, but of course, having multiple supply chains can be especially important in a situation like this when all of your surrounding communities are impacted and making similar requests. So your facility should ideally have mutual aid agreements with nearby facilities before sending up the resource requests up to the local health departments. These requests just go up the chain. So eventually, if you were didn't have enough supply chains, you may end up having to ask the federal government for support from the Strategic National Stockpile, or again, like I mentioned before, for staff using some of the disaster medical assistance teams. You can also use potential partners like International Medical Corps and some of these other non-governmental organizations looking to send supplies and staff and stuff, as well as even surge sites. So sometimes having states have agreements with these non-governmental organizations, and it's actually a little bit cheaper than asking the government for support. But Gianna, do you have anything specific talking about resource requests with concern for utilization of healthcare coalitions?
I will say that I'm still learning about this. And we talked about a little bit, again, not to go back to last week too much, but we talked a little bit about the role of health centers and how coalitions help us further define our roles and the exchanges that can take place. I have seen and heard from health centers across the state that coalitions have played a role in fulfilling resource requests. We talked about the scarcity of some of these resources. And I can say that second bullet on this slide, much easier said than done, right? In a time like this. But with that said, it doesn't prevent us from voicing our needs. I think that's the thing that we have to keep in mind, that sometimes when our requests don't come through, we have the tendency to not ask again. But one of the things I would say, and part of our role at FACHC, is to continue putting these requests forward, because I do believe as we start to move through this pandemic and come out on the other end, it will be more clear than ever the role that community health centers are playing and how resources need to be allocated towards these community-based partners. So that's my 2 cents. And if you are having trouble sort of connecting with your coalition or trying to figure out how to route your resource requests, you can always reach out to me and we can work on it together to find out where is the right place to send those requests. That's it.
All right. And finally, coordinating with response partners. This is just talking a little bit about having your facility emergency operations center set up, and that could ideally use the incident command system. This is the best way to coordinate with some of your outside partners because you have dedicated people sharing surveillance information and situation reports with agencies outside the hospital, your public health departments, any sort of agencies that you are working with, and your facilities, your employees themselves. So I think that it is important to have something like an emergency operations center that uses a standardized system set up to help with this. Gianna, do you have anything else to offer?
Yeah, no, well, I just wanted to mention once again, we talked about the role, and every community is different. And we all have, a lot to consider when we take a couple steps back and try to get a sense of who's doing what. And especially when you have multiple sites serving, communities with unique needs. These are all things to think about and communicate with your response partners, as soon as you can. Now, when it comes to incident command system, This is something that is used just at every level of government. So that gives us this common terminology in health to use and to sort of understand how they're breaking up the roles and responsibilities within their own structure. Again, it doesn't have to be adopted sort of by the book. And I know there's also HICS, the Hospital Incident Command System, right? But we can always take elements of this when we're looking at how we create our teams and how we're looking at planning to give us a guide. So one of the resources that is included and will be sent out is some ICS training. If there is interest in sort of exploring this for health centers, it's something that I would love to delve into deeper. But basically, you know, in also in an infectious disease outbreak, it kind of gives you that assurance that the right person with the right background and skills is going to serve as the incident commander, right? So if depending on the type of event you have, certain scenarios, your CEO may be your incident commander, but maybe for something like an infectious disease outbreak, you have your CMO actually stepping into that role, given their background and clinical expertise. So again, just something to look at in terms of a structure with flexibility. And as we go into the next slide, there's the description of the surge template, which I have since dropped into our chat. And you know, this is something that's referenced in that surge template, this use of some of the terminology from the incident command system to help you sort of explore how this can be adapted for your health center's use. And I see a comment here in the chat. Yeah, thanks, Tom. Comment about telemedicine, about powerful tool for surge and follow-up, definitely. And I would invite anyone, you know, to comment about their current surge plan, if they see this as something that's sort of standalone, or maybe something you just put together in response to COVID, or has this sort of been woven into your all hazards plan? I know these plans can get a little bulky at times, but I think the template that IMC has provides us with a lot of good language that even if we don't adopt this plan, we might want to pull out our copy and paste and take some of these elements and put them into an existing plan. You'll some of the sections that are in the plan, and like I said, to each their own, given, you know, your unique needs and current plans. But it's just an additional resource that will go out after the webinar today, along with the slides. So I think that maybe all that we have, it might be time for us to turn it over. Is that right? Yes. Okay, yeah. Great. This is what no offense to anyone else, but I've been waiting for. I would love to hear from our health center partners here on the line. We have Kim Shuknik, I hope I said that right, the Chief Operating Officer at Community Health Center of Pinellas, who's also joined by Steve Kelly, Environmental and Health Safety Coordinator. We know you've been busy, Steve, on the line to talk a little bit about their health center's approach when mobilizing for COVID-19. So I'll pass it over to both of you. Thanks again for being here.
You're welcome. Thank you, Gianna. I don't think that we've done anything differently than anybody else. I think that what we did quickly was I think the first or second week in March, we decided that we needed to activate our emergency response team. And we have a robust emergency response team that has very specific duties, typically used for hurricanes, obviously here in Florida, but it really gave us a good outline of what we needed to do. We have about 15 people on that team, and we were able to really focus on three major areas: on patient employee safety, meeting the patient's needs in, however we could meet those and address what the community would need. And then how do we have financial stability as we try to weather all of this? So we each took our roles and kind of ran with it. We had our CMO working closely with our infectious disease consultant. I took on the staffing and looking at staffing and what that needed to take place. I became a chief purchasing officer along with Steve and didn't plan for that, but it was quite the process, just trying to get ahead of the inventory. We knew quickly that we were going to face an inventory issue, and we quickly pulled all excess inventory from our centers and created a central inventory. And then 3 or 4 of us were up at 11 o'clock. We're texting each other at 11 o'clock at night that I got 10,000 masks. You work on other items. And it was just a really well-coordinated effort. And I'm proud to say we didn't have any PPE shortages. We had contacts with a local vendor and were able to get P100s and plenty of the respirators. And, you know, it was just a really coordinated effort. Then we had to focus on staff. We knew that we'd have positives eventually, so what do? We took our dentists and our chief medical officer tooled them to do triage over the phone to get folks into our testing centers. We had wellness centers. We very quickly determined we needed a wellness center. So we had our 4 large centers seeing the bulk of the sick patients. Our smaller centers became very well-contained wellness centers. We made sure staff we put quickly a COVID PTO policy in place, and within 2 weeks, we had almost 90 staff working from home. So we deployed everybody very quickly home. We looked at our senior leader team, said we can't go down, all of us get sick, we can't be working in the same building, so we all scattered and worked somewhere else, either from home or another center. We worked, you know, it just was almost seemingly, I know it doesn't sound like it can be, but we worked pretty well to get it all taken care of. We paid for childcare for 4 months. Anybody who needed childcare help, because we needed all hands on deck, so we were able to pay for some childcare. We determined that eventually we were going to need we were going to be asked to do testing, and we were going to, when the vaccine was available, we'd have to figure out how to do outreach. So we bought a couple of small vans and tooled them. So within an hour, we can outfit them and send them out to either an ALF, a school, and we can test on site. We had a unique relationship with the lab. We were able to get thousands, and Steve will talk a little bit about this, thousands of rapid tests. We never ran out of supplies. We were very, very fortunate that we were able to do that. We've tested almost 28,000 people to date. And so it's been quite the event. We engaged some temp, just like you talked about. We went to some temp agencies to get some people to run and work some tents. We didn't offer any specific outside services at the very beginning. We opened up a tent for testing, and we had testing available 5 days a week. We engaged, we had one of our emergency response team members that joined the EOC calls every week and briefed us. And we also had a county call that included all of these state-run centers, our center, Department of Health, school officials, a lot of community leaders that we still participate today. And we became one of the first people they turned to give updates. So I think a silver lining through all this is our relationship and respect within the community for what we can do and what value we add has really been tremendous. It's been very heartwarming. You know, you work hard, and to have some for other people to see value that you offer in the community, and I think we've done that. So that's a really silver lining thing for us. You talked a little bit about communications. We had town hall meetings every week. We had emergency response team meetings at the very beginning. I think, Steve, for the first 2 or 3 months, I think we had them twice a week. And then we went to about once every week, and now we don't necessarily have them. We've kind of got the process down, but the communication is still very key in keeping everybody up to date on what's going on in the COVID world and what's happened. We did implement a lot of different IT. It's been super busy. We implemented tables ready like the restaurants use. And we're able to call people and have them come back in when they were ready for care. We Telehealth, we've done a couple of different systems for telehealth. We were about 50–60% telehealth visits at our peak. And now we're about 20 to 25%. I think that's about what everybody is kind of seeing now. But patients like the ability to have the telehealth. We have four of our centers have tents. I'm sorry, 3 of our centers have the tent testing. We started during the day. At the very beginning, we had it all day long. It was so hot for staff. And as the demand started to wane a little bit, we switched it to night, and having night testing seemed to be more utilized because of the not having to take time off of work. We trained our MAs how to do the history and the intake and just the quick interview with the patients to make sure that they were able to be tested instead of utilizing the providers, so we could get them back in the centers to do that. And I think recently that we've our fast track, we have a fast track system at 4 of our centers where 6 hours out of the day, any first responder, any medical, anybody who works in the medical community, schools and teachers and staff, we can test them. They just drive up, there's a number there they call, and we have staff at the ready that comes out. MAs do all of the intake for that and have a provider that's on their team that if they need some help or need some any support, they're there to help them. And we also do A1Cs, we do blood pressure checks. So we're trying to make sure that we cover all those care gaps for people who just aren't ready to come back in the center. So we've done a little bit of everything on the gamut. So and I think we're in it for the long haul. So the fast track is something we plan on for quite a while. We see about 500 to 600 people in our fast track every week with all of our COVID testing, and that's the care gap testing that they're doing. So, Steve, what did I forget? I mean, I think I'm kind of taking it.
I'm enjoying just listening to you talk. Keep it up. I think we just learned to adapt and change quickly, as I'm sure everybody else did when this came up so quick. The allocation word that came in with supplies and the PPE problems in the beginning, we learned that McKesson was our only one, and that wasn't going to work. We had to add more suppliers. We did that early. That really helped. We also learned that, like every other FQHC, you probably have an expansion coming up or some project, and so now we have 3 to 6 months worth of supplies in an off-site location, ready to supply those. McKesson has told us that they actually wiped out their hurricane backup that they had, and so they have no backup. McKesson wiped out their supplies. So if a hurricane hits now, I don't know how long supplies would even come. So we really need to prepare for that in Florida, not knowing who knows how long we wouldn't get supplies now if something happens. So we're looking at maybe wanting 5 to 6 months worth of some of these supplies on in-house now, instead of 30 days worth on a shelf in the small supply room. So we're looking going forward now. We feel we're kind of caught up, but now we're looking forward of the way things are now and how this has changed operations. That everything was delivered tomorrow, and now we can't look at the world like that anymore. Now we're looking at what we have to keep in house, how to rotate stock. It's the days that it used to be. It was so convenient to order overnight and not worry about it. Now things have changed in the ordering supply world, and I guess, like Kim said, the testing, we have learned we have to adapt to how they want it. Some weeks we're busy, and then they want it only at night, and it's all about change and adapting to what the need is out there right now. And it's the team we had and bringing things out. I don't want to say it's good having the hurricane once in a while on these drills we have, but that's how we built the strong team in rapid response, is having these drills and these things and these close calls where we have to be in close contact and work with each other on things like this. So.
And two, I think it made us look at the equipment that we have. We have to be more proactive, make sure we have the latest and greatest equipment. Steve had the forethought to look at our Sophia machines to see if they were compatible with testing, using them for the rapid testing, which they weren't. So back in, I don't know, Steve, March or April, before everything really got crazy, he was able to get all of our machines upgraded and get an order in for the Sophia machines. And we were lucky enough to have 12 or 15 of those delivered when most people couldn't get their hands on them. So we, I think the forethought that went into a lot of this was.
We were one of the first to have, and we've got like over 12 or 13,000 tests in stock and all the machines for rapid tests for COVID right now. And we've already done, what did you say, 20,000 or so. So we were fortunate to have those machines in place and be able to do rapid tests when nobody could. And that was one of the lucky ones, but we're always trying to keep things ahead. And when we have an opportunity and we can, we just try to stay ahead of the curve.
Awesome. Thank you so much, Kim, Steve. I know we're coming up on the hour. That was amazing to hear. And it really brings home the messages that Dr. Moore has shared over the last hour, and how having a really collaborative team of people contributes to the ability to just take this from a plan to action. And I mean, that's our goal, right? Planning is great, but when an emergency happens, it's about people coming together with a common understanding and common goals. And we love to hear, not that it's been without its challenges, but we love to hear these wins. And I'm a local in here in Pinellas County, so I can attest to the fact that you are very visible and seen as a very valued community partner here in my own community. So thank you for all that you do. Natalie, if we can move, and any questions, any comments, please drop them in the chat. I did also include the evaluation there. I did want to let folks know these resources will come your way in a follow-up email. The plan template, the ICS training link. I thought this report was really cool from Asper Tracy. It's about medical surge and the role of health clinics. It'll be interesting to see if they do a follow-up report post-COVID. Let's stay tuned for that. And then of course, on our website, the FACHC Emergency Management Knowledge Base, and just FACHC generally speaking as a resource. I hope that all of you feel comfortable reaching out to me for preparedness support. I don't have all the answers, but I am more than willing to reach out on your behalf and try to get answers when we don't have them, or connect you with resources. I'm going to pass it over to Ryan, who can close us out. I also, again, want to give a shout out to Tom before we go. I don't know if Tom has any final words. I'd love to give him the mic for just a moment, or I don't know. Tom, you there?
The only thing I'd ask, does anybody have the 800 number to the Hurricane of the Month Club? I would like to unsubscribe.
That's your phone number, Tom.
Thank you, Steve. No, I think it's a right on target call. I'm glad I was on it. Kim and Steve, your insights are great, as are yours, Dr. Moore. Everything you said was completely accurate. It comes in bits and pieces. The only thing I'd chime in on is that telemedicine has really helped out in the last couple of months. We're utilizing that for follow-up for some COVID issues. We've already got it out there for schools. We're just it's an interesting tool that we repurposed, and I see that growing with FQHCs to begin with. It's just been a tremendous tool to use at the right moment.
Thank you, Tom. We so value having you here in our community. We're glad you're still with us. Thanks.
Yeah, thanks so much. Tom, it's great to see you again. I look forward to catching up at some point. But just to close us out, we just really like to extend a huge thank you to Dr. Natalie, to Gianna, and also to Kim and Steve, just for sharing your experiences. I think we all it was great to hear your, just immense effort. So just thank you so much. I do want to let everyone know that this webinar is going to be made available on the International Medical Corps website, a link to which Gianna will be sending out. You'll also be receiving this slide deck in PDF and also a copy of the medical surge plan template. Please share the resources with anyone that you think may be interested. But please also complete the evaluation. The link is in the chat, and the code is also here on the slide for when you receive the PDF. But otherwise, on behalf of International Medical Corps and FACHC, thank you so much again for joining us, and have a great rest of your week. Thanks so much, everyone.